Hi everybody, welcome back. My name is Mark. I'm a senior osteopath here at ML Therapies, and in this first video we're going to show you how to posteriorize an anterior innominate, or a pelvis that is tilted forwards on one side, usually with an in flare. So we've already determined with this patient that we have a left-sided anterior innominate and we have a posterior right-side innominate. So the true positive on this, based on our standing flexion test versus our seated flexion test, was left-sided iliosacral dysfunction. We've done some alternative assessments to determine that we have a left side long. I generally do a left posterior for this and a right anterior. So I'm just going to show you the setup for our left posterior adjustment to posteriorize an anterior innominate. So tracking across the iliac crest, come down and palpate the left-sided sacroiliac joint. We leave the underleg straight, we bring the left foot up, let it rest into the popliteal fossa. Now we can bring it up a little bit further, and what we need to find is just a slight little bit of posterior motion to posteriorize that anterior innominate. Once we feel that posterior motion at the PSIS, or the posterior superior iliac spine, we know we have the right spot. When we track across to L5, we place one hand onto the hips. We just place the thumb over the hand, place one hand through onto the opposite elbow. We lightly rotate through just to lock out the spine, so we're not including spinal motion here. And sometimes a little bit of extension just to finish locking out the spine. Place one hand over the other, bringing it forwards. And if the patient then can actually grab onto their own elbow or forearm, my left hand is now placing across the upper thoracics, not to push or squeeze or rotate too much, it's just to hold. Now from here, what we do is ask the patient to look up towards the ceiling, because sometimes in this position they can feel a little bit insecure and unsafe. So we step to the inside of the thigh. What we do then is I place my thumb across the SI for palpationary reasons. Because we need to posteriorize, we need to hook under the ischial tuberosity. We already have the barriers met, or locked to, not met yet, we have them locked to. So from here, we need to posteriorize through the ischial tuberosity. So from here, we place chest towards the patient. We apply pressure posteriorly through the ischial tuberosity. And then once we find the bind, we can pump this a couple of times. We are careful not to over-rotate or put too much pressure down to the thoracics. That's quite uncomfortable. So from here, palp, just to find, using the palmar aspect of the forearm, not the elbow, which can be very sore as well. Just palping through, find the bind. Once we have the restriction met, compress and thrust. And in this video, what we're going to show you is how to anteriorize a posterior innominate that usually occurs with an outflare. So in this instance, what we're going to do is to anteriorize the right side innominate that is seated posteriorly. So what we need to do is straighten out the underleg, the one that's closest to the table. We place the dorsum of the foot into the mid-gastroc area, and this slightly anteriorizes the posterior pelvis, keeps it in a slight anterior position. We place one hand onto the top of the hip, okay? The other hand comes through the upper side of the arm. We rotate the patient down through, palping down through, so that we lock out the lumbars. Clasp hand onto forearm, loop through. Again, this is just to hold, it's not to apply too much pressure through. Now, we know our landmarks. We come across our iliac crest, 45-degree angle inferiorly to find our PSIS. So I'm palpating the PSIS here with this hand. Now, one of the adjustments is to posteriorize through the ischial tuberosity in a rotationary fashion. In this case, we need to anteriorize. So we need to use what we call the osteopathic sulcus. We need to traction the patient towards, and this time we're anteriorizing down along the line of the femur. So we bring the patient in, compress, pump, compress, compress, meet the barrier, and thrust. Hi everybody, so what we've just demonstrated is how to posteriorize an anterior innominate through the sideline modified lumbar roll position, and how to anteriorize a posterior innominate again through a modified lumbar roll HVLA manipulative adjustment. So if you like what you see, guys, click and like and subscribe. And if you have any questions or have any specific requests on adjustments or any other mobilization techniques, just pop us a private message. And thanks for watching, guys. See you later.